I would like to welcome everybody. Good morning, good afternoon, depending from where you're joining today. My name is Sharbani Chakraborty, and I'm Senior Technical Advisor on Health Financing to the Access to Oncology Medicines Coalition. And Megan, I cannot see the slides. I'm wondering. Perfect. Thank you so much. Okay. Can we? Perfect. Thank you so much, Megan. These last-minute technology glitches always make us nervous. But in any case, welcome again. And I would like to kick us off this morning for those joining us to present a little bit about the ATOM Coalition so that we are grounded in what we are trying to do. And then I will be handing over to the IDA Foundation, our partner, to talk more about specific access pathways. Megan, next slide, please. Okay, next one as well. Thank you. So for those of you who are not familiar with the ATOM Coalition, this is led by the Union for International Cancer Control. And I think everybody on this call is aware of the enormous problem with access to quality assured oncology medicines and their affordability in low and lower middle income countries. And in 2022, to address this really important global health challenge, the ATOM Coalition was launched. And we are committing to addressing the challenge, of course, of the availability, affordability, and appropriate use of oncology medicines and diagnostics in low and lower middle income countries. Next slide, please, Megan. So just to tell you a little bit about our three ambitions, and we are going to talk about one particular ambition today. The number one ambition is to make available more WHO, EML, generic, and biosimilar cancer medicines over time. Right now, less than 50% of medicines on the EML are actually available in low and lower middle income countries, and you will be hearing today from our colleague Utra, and then of course from Callie Weber from the IDA Foundation, the access pathways and mechanisms we have developed to help countries achieve this goal. Our second goal is to secure an increasing number of patented medicines and new medicines in the pipeline over time. As you're all aware, there is an issue with global health equity because often innovative medicines are available in high resource settings, but to bring them to low and lower middle income country contexts requires us to work a bit harder and develop mechanisms that actually can foster access. And we'll talk a little bit more about that, although in this webinar, we will not be focusing too much on that. And finally, we also look at the ecosystem for delivering the medicines, because if the medicines are made affordable and available, but the mechanisms are not in place to get it to patients on time and in a quality manner, then we will not achieve the health outcomes that we wish. So we work along this three-pronged pillar to address these issues, working with our partners and our countries. Next slide, please, Megan. We have over 40 partners. Our partners include innovative pharma companies, generic and biosimilar manufacturers also are in the pipeline joining us. And we also have a whole host of organizations that focus on quality delivery of medicines, including the infrastructure and the ecosystem needed to deliver those medicines. The next slide. Yeah. And then to talk a little bit about focus countries, because I'm sure you are quite curious where we are working. Actually, we came up with the list of 46 countries, which would be part of our phase 1 interventions. And this was based on the World Bank low and lower middle income country guidelines of which countries fall in this category, but also based on other criteria, including what the countries were already doing around oncology. For example, do they have a mechanism, awareness generation activities, are there active civil society organizations, etc. And you're probably wondering why we have marked 3 countries in yellow. What we actually did is, among these 46 countries, we have come up with 10 countries that will be our countries where we do intensive capacity strengthening activities, really testing a lot of tools and mechanisms, which that can be scaled to the 46 and eventually to the rest of the world. The ATOM Coalition is a global project. So many of the mechanisms and the learnings from the 46 are going to be available for all countries eventually to use as they wish to address the topic of access to oncology medicines. And I'm going to talk a little bit about the 3 countries that have been highlighted in yellow. Those are our 3 pilot countries. So we are currently working rather intensively in Mongolia, El Salvador, and Zambia to test both our access pathways and our capacity strengthening activities. In Mongolia, we have already signed a MOU, Memorandum of Understanding, with the government, with the MOH. From our perspective, once the MOU is signed, then all our activities can start rather intensively in the countries. We did the official launch in May 2024. We have already completed our baseline assessment, which is an assessment of the ecosystem around which the medicines will be delivered, such as regulatory, pricing and reimbursement, or access to pathology and diagnostics, as well as safe delivery and access for patients. We have completed this. We are currently doing the health financing diagnostic. And finally, our in-country workshop is planned for Q3, Q4. What happens during the in-country workshop is the multi-stakeholder technical working group in the country needs to look at the data and come up with a jointly owned action plan, which then becomes the basis for our capacity strengthening and access activities. We have also signed our MOU in El Salvador. The official launch has happened. We are kicking off the baseline assessment, and we are also hopeful that already by Q1 2025, we will have developed our list of capacity strengthening activities. And finally, Zambia, we are in the process of signing the MOU. We have launched the health financing diagnostic, and we are also hopeful that by Q3, we will be able to launch our baseline diagnostic there. So with that rather quick overview of the ATOM Coalition and our country activities, I would now like to hand over to Mr. Uttra Kumar, who is a core member of our access team. And he's going to tell you a little bit more about our access pathways. And then then Uttra will hand over to our partner, the IDA Foundation, for their presentation. Uttra, can I hand over to you, please? Thank you.
Thanks a lot, Sharmani, for a great introduction. So I'll spend a couple of minutes on improving medicine access. The cancer medicine targets that we are looking at as a coalition are of 2 types. One is generics, biosimilars, and patented medicines which are currently on the WHO EML. And the second type is critical medicines for 6 priority high incidence cancers, which is breast, cervical, colorectal, lung, prostate, and pediatric. And how we go about doing it is to work with companies who manufacture drugs and partners to define sustainable medicine access pathways. We have 4 such pathways already defined with various partners. The first one is your licensing model, which is with our partner Medicines Patent Pool. The second one is donation model, which is through Max Foundation. The third one is indirect commercialization. And the fourth is NCDconnect platform. Both indirect commercialization and NCDconnect platform is with our partner IDA Foundation, whom we'll meet a bit later in the call again today. Moving on to the next slide. So I'd also like to maybe highlight a couple of case studies on the work we've already done on medicine access. The first pathway we worked on was licensing. The product was nilotinib, which is a 2nd generation tyrosine kinase inhibitor used in chronic myeloid leukemia, with the innovator company being Novartis. In 2022, Novartis announced a non-exclusive license agreement for nilotinib through ATOM Coalition along with Medicine Patent Pool. And 44 countries were included in this voluntary licensing. 4 generic manufacturers have already been selected to commercialize nilotinib in these countries. And these licensees are in the process of obtaining the regulatory approvals. And we expect the launch of a generic nilotinib in some of these markets by end of 2024. The second pathway is indirect commercialization. The key product over here that we worked upon was nivolumab, which is an immunotherapy with more than 20 plus indications, with the original company being BMS. The partnership was announced in May 2024 between BMS and ATOM for the indirect commercialization of nivolumab, starting with 3 countries for 24, which is Pakistan, Rwanda, and Zambia. And we plan to expand to more than 15 countries over the next 2 years with this product. The third case study is on NCDconnect. which is with our key partner, IDA Foundation. I won't go through it in detail, but I would like to invite Callie Weber from our partner, IDA Foundation, to take over and walk us through both IDA Foundation and NCDconnect. Over to you, Callie.
Thanks, Uta. And hi, everyone. My name is Callie Weber. My background is in bioengineering and global oncology capacity building, and at IDA, I'm our market access specialist for NCDs. I'm also joined by my colleague, Agosa Ramnats, here. So to give a little bit more background, for those who aren't familiar, IDA Foundation is a nonprofit organization based in the Netherlands. Our story began in the 1970s, where a group of pharmacy students from the University of Amsterdam really saw the disparities in access and wanted to bridge that gap by addressing it in the supply chain. And we really stayed true to that vision and mission. Our goal is to bridge these gaps so that healthcare workers have access to high quality, reliable products at a fair price. And over the last 50 years, go to the next slide, we've grown to have quite an international presence. We have 220 employees representing 25 nationalities with agents and distributors in over 30 countries. So you can see on the map, the yellow, orange, and blue are where we have agents and distributors. Our headquarters are the dark blue in Amsterdam in the Netherlands, with a secondary office with about half of our team in Mumbai, and our warehousing is centralized in Dubai. And so IDA Foundation is structured between our wholesale and our procurement services. With wholesale, it functions as a typical wholesaler. Some on this call may be familiar with IDA products. And here we serve over 500 customers. We work with international and local NGOs, large funding organizations, ministries of health, central medical stores, as well as smaller mission hospitals. In our procurement services, it's more of a programmatic and end-to-end management approach. So examples here include the Global Drug Facility, GDF, with our Stop TB partnership, where we've worked in over 20 years in the distribution of tuberculosis medicines. Last year, we delivered medicines to over 130 countries globally. And so we have over 50 years of medical supply chain and diagnostic experience, focusing primarily, nope, you were right, Megan, focusing primarily in the NCD space. And with the growing burden in focusing primarily in the infectious disease space. And with the growing burden in NCDs and especially in oncology, we're working to transition some of our experience and know-how and successes to solve some of the problems in this area. And so before we can go to solve the problems, you have to understand them. And this is based both on our experience in global supply chains, especially in low and middle resource settings, as well as specific to the oncology context. For example, the accurate and consolidated forecasting, there's challenges in fragmented sourcing in which procurement officers have to work with many different channels and distributors in order to source a complete cancer regimen. There's also a strong challenge of lack of transparency and a very fragmented supply chain, which leads to multi-level price markups that get passed on to the patient in an unsustainable manner. For cancer specifically, there's a challenge in access to the innovative and life-saving medicines. Some of this is because with the mandated tender systems, those don't get replied to, or medicines aren't always delivered on time and in full with the negotiated agreements. And finally, quality. 1 in 10 medicines on the African continent are substandard, and that is absolutely not acceptable. And so that's heart of IDA and has been for the last 50 years in our quality assurance. So NCDconnect is a online digital platform that consolidates the demand and simplifies the process for the user. And essentially how it works is that a user can, one of you could create a profile on the platform and get access to the catalog. The catalog is complete for non-communicable disease medicines and diagnostics, which I'll give a demo of shortly. And we've worked with over 10 suppliers to come to access agreement contracts with their products on the platform. So it's a consolidated space to access a variety of products from a variety of vetted suppliers. You're then able to add the products you want to a basket, receive that quotation, and then go through a very transparent process with IDA having ownership over this entire supply chain process. And so there's clear transparency, and as a nonprofit organization, there's a guaranteed in minimizing markups and sharing that value, sharing values to pass on all cost savings to the end patient. So as a snapshot onto what's available in the oncology catalog and our process behind it, we currently have 32 molecules which are listed here, which translates into about 75 formulations or strengths on the platform. We did a pretty intensive market analysis to curate this catalog, including looking at the WHO EMLs, as well as some national EMLs from low and middle income countries. We also looked at a Lancet article that identifies the top 20 demanded medicines and LMICs with input from over 80 oncologists globally. And we compared it as well with national treatment guidelines, including the NCCN harmonized guidelines and non-harmonized, to ensure that we have access to complete cancer regimens on a single platform for the top incident cancers. And just one more point on the catalog is that it is changing. We take market input. If there's molecules on there, strengths that are needed that aren't there, our sourcing team is working really hard to make sure that what we have is complete and is what you need. So if there's anything that's missing, that's always helpful feedback for us to receive. As I touched on quality, all of the products that are listed on our catalog fall into one of the three qualifications. They're either WHO pre-qualified, they're approved in an SRA country, or they have an IDA qualification, in which we have a team of QA and pharmacists who conduct full audits on site of GMP, as well as dossier reviews and batch testing. And we've been successfully audited by all of the organizations on the left of your screen as well. And so here I will steal the screen from Megan and give a short demo of the platform, just to give a little bit of the look and feel as to what NCDconnect is and how you can use it. So you should be seeing it here, and you can see we have it currently available in 6 languages, and we're continuing to work on translation to ensure that it is globally accessible to our audience. Our users are ministries of health, central medical stores, international or local NGOs, as well as mission or faith-based officers. So it's not limited to the public sector, though our mission is to be able to serve high quality, affordable medicines to the public populations. We have a sign-up process in which a customer must be able to, for instance, demonstrate that they have the legal ability to procure and distribute medical commodities within their operating markets. And once we've done our customer onboarding process, you can sign into the account. So I'll sign into yours or to mine for the example. And here you're able to start to see the catalog online. So into our oncology catalog by the different subsections, you can see also cardiovascular and diabetes. So here you can see all of the different products as they're listed in the catalog with many more pages. I'll click into an example of cisplatin, where here you can see all of the available information and packaging, as well as the specifications, including dosage form, packaging unit, transport or logistic conditions, as well as the approved indications. So this is, one thing you'll note is that we do not have the supplier or the price listed directly on the platform. And the reason for this is that for many of the products, we have multiple suppliers contracted for a single product. And so this ensures our ability and redundancy to be able to respond in a timely manner to all of the requests that come in, and also do matchmaking. For instance, if some suppliers have products registered in certain markets or are more affordable, we're able to give the best price given the parameters of registration, of volume, and of MOQs and lead times. So this is the product that you want. You can add it to basket. Go into the basket up here, where you're able to see all of the items that have been added. You can change quantities or delete solutions just as you would on any e-commerce management. You're also able to divide baskets into lots. For instance, if you're a Ministry of Health that has 5 cancer treating hospitals in your country, you can divide it up into those 5 different lots to support the clarity and forecasting and digital management from the consumer or customer side as well. Once you're happy with your basket, you can go through and provide all of the necessary information, as well as requested quotation date and delivery date. The currencies accepted are US dollars or euro, as well as your Incoterm. So whether you want it delivered directly at the institution or simply at the port. If there's any specific documentation that are required for delivery, as well as any specific requirements. So for instance, this would be if you are only able to accept SRA approved products, or if the place of delivery is closed on weekends and it must be on Monday through Friday operating hours. And so once all of this is filled in, you can publish the RFQ here, and then that gets sent back to our team at our IDA. Our customer management team is able to respond with a quotation and then go through the PO and delivery process. There are many other basket management and abilities to share and merge between users or between organizations. But for the purpose of this demo, I will keep it pretty short and simple. Excellent. And so just to round off, for NCDconnect, our goal is to really coordinate the procurement and to provide an easy digital solution to the fragmented sourcing in the oncology space. So for one, it's a digital solution for NCDs, providing all the medicines, medical supplies, and diagnostics in one place where we take on the management of different suppliers and the user gets a single catalog to look at. We coordinated procurement by connecting the buyer's needs with the supplier's solutions in a coordinated management way. You're likely familiar with the term pooled procurement, and what we do is a little bit different, but to a similar purpose and value creation. And that, for one, it does drive down prices by coordinating some of the volume demands from distant customers in order to meet MOQs and have those lower prices associated from suppliers. We also are able to have, however, we're able to have a little bit more customization and product selection. So rather than coming with a list of 10 molecules that are available for pooling, we have a full catalog and the customer is able to have that decision on what they need based on what's on their EML and treatment guidelines and patient populations. And then the coordination and procurement comes on the backside. There's also transfer of buying power to the countries directly. There's country ownership and country-led procurement systems that are empowered via this system. And finally, it's a digital access to a catalog managed by one entity, IDA. And we have over 50 years of experience in procurement, supply chain, and quality assurance. Then finally, as we're here with Adam and with UICC, our goal with NCDconnect is to really fit it into an integrated ecosystem. We are working hard to foster partnerships, both with international organizations as well as local NGOs, Ministry of Health, Central Medical Store level, within the civil societies and communities. So your presence and engagement is critical here as well.
Great. Thank you so much, Kelly, for that excellent presentation. So, Megan, we can move to the next slide before. So what I would like to mention, and there are already some questions on the chat asking, you know, is Nigeria included in ATOM and others? And I think one thing I wanted to make clear, I mentioned it at the beginning, that all the work we are doing is for all countries, basically. And our partners as well, the access pathways and what Kelly presented today, if this is something you feel could be a valuable solution for your country, given the country and context, you can definitely do a lot to raise awareness and advocacy around this topic, as well as bring to the attention of key stakeholders in country that such solutions are available globally. So we encourage you to do that. But Kelly, there are already some questions coming up, and you know, there are some really good questions. And I think one question I would also like to ask you, which is the NCDconnect only for low and lower middle income countries, where of course there is a large problem with access to affordable oncology medicines, but we have a colleague from Malaysia who's asked, how can I access these tools and resources? And I know from my experience that in many upper middle income countries too, governments are struggling with procuring affordable medicines for people who live below the poverty line or a low income population. So does the IDA Foundation and NCDconnect particularly have a policy around which countries you work with? And then we have some other questions, Kelly. Over to you. Thank you.
Yes, so we work with all low and middle income countries. Organizations and governments of those are eligible to use the NCDconnect platform.
I'm also helping Kelly answer some of the questions in the chat box since she's presenting. So I'm actually replying most of the questions in the chat. For example, on this question that Kelly asked, our focus is lower middle income countries because it's really an access initiative to offer these commodities to places where access is actually a challenge. And so for the suppliers we have contracts with, they also define for us some, they can define exclusivities to say that, okay, you offer our products on via the pricing you get on NCDconnect in these kinds of countries. So if we have those kinds for a particular product that is required by one of the buyers, of course, we would have to respect our contracts with the suppliers. However, on NCDconnect, we strive to have multiple suppliers for the molecules that Kali showed, so that the fact that one supplier may have that exclusivity does not mean that maybe you'll be able to access it from another supplier. So we are working collaboratively, looking at all the regulatory requirements. And yes, our ultimate goal is actually to focus on LMIC markets.
Thank you very much. So we will keep this contact information slide up for anybody who wants to contact either the Atom Coalition team or IDA Foundation. But then we are also now opening up for Q&A. And Ego, did you answer all the questions, or do you want me to start reading out some of the questions as well? We've been trying to keep up with the chat so far.
I'm still answering. I've not finished answering all the questions. But if any of the answers we provided, if they require any clarifications, I think they can do that. But I will continue to answer the questions. If we are able to take some in the conversation, fine as well.
Perfect. Ego, thank you very much. So we are open for Q&A. So you can either post on the chat, or you can just unmute yourself and ask your question directly. Thank you.
Hello.
Yes, please go ahead. Please introduce yourself and your
Yes.
organization and pose your questions. Over to you.
Thank you. Thank you for informative presentation, and it's good to have opportunity to join this session. My name is Sukurab Salif, representing the Max Foundation from the region of East Europe and Central Asia. I saw among the list of countries under the focus is Georgia, Kosovo, Kyrgyzstan, Tajikistan, Uzbekistan. As long as we are capturing these countries, for me, it's interesting to learn. Does it mean that these countries are eligible now for services providing Atom together with DI? Is it, I understood correctly? I mean, what services are offered for these countries, let's say? And question number 2 is, you highlighted about Mongolia now. You already signed the memorandum of understanding, and you're on a pathway to have a workshop in Q3 and Q4, probably in autumn. What's the next step? I mean, what is Mongolia going to have access to? What services or drugs or yeah, these are the 2 questions from me. Thank you.
Thank you. Thank you very much. I will try to respond. And of course, my colleague should also chip in. So maybe I'll answer your second question first. So the way we work on capacity strengthening is we do the situation analysis to understand where are there gaps around, say, regulatory, pricing and reimbursement, access to pathologies and diagnostics, supply management, and making sure that the medicines reach patients in a quality way. So once all of this data is collected in country, the idea is that a multi-technical stakeholder group, which consists of government officials, of course, oncologists and other providers, civil society members, often people living with the disease as well. So this group actually meets to look at the data all together. And then based on that, and as well as examples of good practices globally, the country then comes up with its own action plan. So for example, if it is identified that there are barriers around regulatory, then there will be an action plan developed to address that. If it's supply chain management, then we may have some partners, for example, the IDA Foundation and others, who could help us figure out how the country can move towards, say, coordinated, efficient procurement. So that's why we have over 40 partners, because the Atom Coalition is a very small team, and we are specifically called a coalition because we are like a convener, and we try to connect countries with partners so that they can work among themselves. So that's our modus operandi of working. So we are really a connector, networker, we create a marketplace, and that's how we work. And so Mongolia would then be eligible to access all our partners and even more to solve their problems around access to oncology medicines based on our baseline assessment. To respond to your question about the selection of countries, you're right. And often the question is, how come I was not included, or why is this country included? This list was actually very carefully developed to serve as these are countries that will hopefully generate good examples and learnings about how we can implement the Atom Coalition model. And then based on those learnings, these have become generalizable. So for example, if we work in Georgia, we hope that some of those similar lessons are applicable to countries that do have universal health coverage. So for example, Georgia does cover oncology medicines in its benefits package. So you could look at that, or it's Kyrgyzstan. So we hope that each of these countries will generate lessons that are generalizable so that the rest of the world can say, hey, my country looks a little bit like Kyrgyzstan. I think I can access the similar tools and resources and do this on my own. I hope I've answered your question, but if not, please do reach out to us as well. I see another hand up. Please go ahead.
Thank you. Thank you very much for the wonderful presentation. I do appreciate the kind of work you are doing. I really want to, I just really want some clarification about the partnership. I am Weche Robinson. I'm coming from the northern part of Uganda, and I would like to know how we can partner and work together, and then also about our work. We work with cancer patients. Actually, we deal with the most poor people in northern Uganda, where some of them do not have access to the drugs. Some of them cannot afford to even transport themselves to access the medication, because in Uganda, cancer drugs or cancer services are centralized. It is not in northern Uganda, where someone has to travel about 350 kilometers to access this service. What are you saying about the most poor person who cannot really access this service? Thank you.
Thank you for that question. And actually, one of our team members from the IDEA Foundation was in Uganda recently. We just had a visit from the Atom Coalition to start discussions with the Ministry of Health on the Atom Coalition. Ego, would you like to come in here? Because I think it's a very valid question, which is on access, especially for rural populations as well. Over to you.
Okay, thank you, Sabani. Yes, thank you, Wese. We were just in Uganda 2 weeks ago. We've met with the Ministry of Health. As you know, Uganda is one of Atom's countries that we would be working with. So discussions are already underway. We're also working with UCI. UCI is already planning to decentralize to 4 other regions. And so through all of these conversations, they are also, they have access to all of these offerings that we are discussing here. And so we see things actually moving in the right directions. Additionally, we are in discussions with JMS. So, you know, JMS serves the churches and kind of goes into the interior. So we are anticipating that through all of these channels, some of these concerns you just raised will actually be addressed in the near future.
Thank you, Ego. And if you have further questions on Uganda, you can, of course, email us and we'd be happy to share. I think Ms. Jaitley, you had a question.
Yeah,
Yeah.
I'm Swarnima Jaitley, and I'm from India, and I work in as a head of philanthropy department in 500-bedded cancer hospital in Delhi. So, as we get a lot of patients who cannot, there's affordability is a big issue in India. So, my department is what we help needy cancer patients. So, how, as a hospital, is it a possibility for us to partner, or it has to go? It has to happen through the government. What is the procedure?
Thank you, Ms. Jaitley. So we haven't started our activities in India, but I can tell you from our overarching, the way we work, the MOU is always with the government.
Okay.
But our key secretariat in country is always a civil society organization. So a UICC member is usually designated as our secretariat in country. And often these secretariats are coalition of partners as well, basically.
Okay. So as a hospital, we are a member of UICC, and we are not a government hospital. So we are a trust hospital.
So we haven't, so it has to be with the MOU, but then as I was mentioning, and as Callie mentioned, India would qualify, Callie, as a low and middle income country. So depending on the number of patients you have, it is also possible for your organization to directly contact the IDA Foundation and say, how can we ensure? And also, Ms. Jaitley, I'm working a lot on this topic of affordability, and there is definitely a whole issue around the price of medicines. But we are also developing and looking at different tools to support health financing. And as you know, that's you need to have some upstream mechanism. So maybe you're already doing that, some sort of pooling of funds or health insurance. So there are many interesting examples that have also been developed in India, for example, around lung cancer, where a loan program was created without interest. So these type of best practice examples we're also compiling. They are not available as yet, but in November we will be having a health financing webinar, and we hope to share some of those good practices as well. Thank you.
Thank you.
I do not see any. Megan, do you see any other hands? Any other questions? This is a really good interactive session that we are having. Thank you for your questions.
Ego, I think there's a lot of questions that are being asked to you. So do you have any of these questions that you think people would really like to? Oh, there's another.
Oh, we have two more hands. So can I hand over to is it Mr. Ramatu? I'm sorry, I probably pronounced your name completely wrong. But please, let me hand over to you for your question.
Hello, can you hear me?
Ms. Ramatu, over to you.
Okay. Good morning, everyone.
Morning.
Good morning.
Hello.
Yes, we can hear you.
Okay.
But yes, please go ahead.
Nigeria.
We are having some difficulty hearing you. Would you prefer to type your question? I heard hello and in and out.
In Nigeria.
Yes.
So I'm actually interested in these access, discussing access to medicines for cancer patients. And I just want to say this, that in Nigeria, we already have a chemotherapy access program that's been powered by the Clinton Health Access Initiative. So I want to find out, and one of the board member of UICC is actually in Nigeria, Dr. Zainab Shinkafi. So I want to know whether Nigeria is actually involved with this UICC access to cancer medicines program. I don't know whether Nigeria has been involved or we have any representation on this before I go ahead. Even though we have an access program, maybe expanding the program will still not be will still be something very useful for Nigeria, you know, given that In Nigeria, we have a population of about 200 million, and that every day the cancer cases are increasing. As centers the cancer centers would definitely need more and more of these cancer medicines, whether the older generations, whether the innovative medicines. I want to know whether Nigeria is actually part of, has anything to do with NCDconnect and the NCDconnect or HATOM. Thank you.
Thank you, Ms. Ramatu. Ego, can I
Yes.
again hand over to you, please? Thank you.
Yes, please. So yes, I was trying to also explain to Romato in the chat. So of course, Nigeria is a very critical country looking at the population and all that. For us at IDEA, we are already in discussions with NICRAT. Like you mentioned, there's already chemotherapy program through CHI that has been running for some time. NICRAT has, however, still indicated interest in NCDconnect because, like, you know, it's bringing access to generics and like a broader range of commodities, and you have the flexibility to pick what you actually require for your hospitals. You are aware that the regulatory landscape in Nigeria is not so easy to navigate, and that was why our approach was to go through NICRAT. Since through NICRAT, it will be easier to discuss with all the government parastatals for all the regulatory documentations and requirements to get the products into the country. You also mentioned, Dr. From Medicaid Foundation, we are also in discussions with Medicaid, but yes, similarly, in Nigeria, what is currently happening is that because of the lack of access to these kinds of platforms like NCDconnect due to the regulatory barriers, most of the hospitals, they just buy just in time. So they have a patient with cancer that needs particular medications and they just go quickly to the easiest source that they can find, and of course that impacts on the cost. A platform like NCDconnect, you're looking at international procurement because of course the sources, the manufacturers, what NCDconnect gives you is direct access to manufacturer pricing, but the manufacturers are not domiciled anywhere near Nigeria, and so it calls for some planning.
Okay, can I connect with you?
Yes,
can you
please.
Get my email and let's connect together?
Yes, please. Yes, please.
I think it's going to be better that way.
Okay,
because I don't right now. I am no more the chairman, but I'm the immediate chairman. So I speak for most of the oncology pharmacists in Nigeria. For 4 years, when that was set up, I have been the chairman, and we just had an election early this year. So we can have a way to connect with you, and you hear from most of the oncology pharmacists. When I say oncology pharmacists, these are pharmacists that are directly working with the cancer patients in Nigeria. So across the 6 geopolitical zones in Nigeria, you have these pharmacists represented. So I will want us to actually have a meeting so that you hear what our problem is, and so that we know how we are going to go forward from there. Whether we are actually involved with the chemotherapy access program of the Ministry of Health. If we connect together, we are seeking to expand how our patients are going to access their drugs, accessibility, and then how it's going to be affordable for most of these patients at the end of the day. So I will please want us to connect together.
Great.
Thank you very much.
You can also share your email in the chat. I've dropped ours. I dropped that for me and Kali in the chat.
Okay. So I will now. Thank you.
Thank you. Any other questions? We have, I think, 8 minutes more, right, Megan?
Yep. And I think actually 3 minutes because we still have to wrap up at the end and talk about Congress that's coming up.
Okay. So we have any last questions? Otherwise, you have our
Can I just put in some question? I'm Dr. Kim from India, Chandigarh. Yes. Your name is Indian, but I don't think you are settled in India, right? But anyway, India is a huge country, as you know it. We have a lot of health facilities. Whatever one can see on the top are for the upper class But is UICC doing anything for the lower class people, especially for India? Because I've not been seeing anything special for India. Because we do, the healthcare system is very bad at the lower level. So I was just wondering whether we can do anything for the lower level people from UICC.
Yes, actually, India is already included in our even the list of first 10. And yes, you're right. I don't live in India, but I am Indian. Yes.
Anything
And so
special?
is
I mean, what kind of, like activity you have included or proposed for India?
So for India, we don't as yet have a memorandum of understanding. But once we have that memorandum of understanding with the government, everything that we talked about in Mongolia, Zambia, as well as El Salvador would also be applicable for India, including situation analysis, application of our access and good practices. For example, the Ayushman Bharat program is including some coverage for oncology medicine. So then the question may be that how do you procure those medicines to make them available? So India is definitely on our list of the first 10 countries where we will start working. So I think for the India colleagues, please do stay in touch with us so that when we start working on India, we can inform you.
Yeah, definitely. That would be very kind of you. But what is holding you back from signing the MOU now with the government?
It's just that we have to take a bit of a staggered approach to doing the work. So we have already Sub-Saharan Africa, as you can imagine, was a priority for us.
Yeah.
Mongolia
Yes.
is a small country, but we wanted to
Yeah,
start.
India is huge, but
So-
you can start, phase by phase. You can't handle it all together, India, because
Yes.
North is different from South, East is different from the West, Central area is different. So you have to select which part of the country you want to. You can start from the Northeast. That is the most neglected part and smaller. Okay?
Thank you.
Please try and start from the Northeast.
Okay, thank you. I have noted your comments and we'll make sure to let you know when we start in India.
Okay, thank you very much, Sarvani.
Thank you.
Sarvani, right? Yeah.
Thank you.
Also.
Thank you.
Okay, it was nice. Thank you.
Megan, I think we can close out now. Any more questions? I think I'll hand
Yes.
over to you two on the Congress.
Yes, I do have.
Sorry, there's one more question. Should we address it before we move on?
Yes, please go ahead.
Yes, I just want to again appreciate the effort you're doing to make sure that our cancer patients really access medication. Our goal is to have all the community affected with cancer and get the right service. And I'm really asking if you've already signed an MOU with the government, with the UCI, then after signing that MOU with the UCI, I need to know whether you have a partner, the CSO that you guys are working with, so that really we can get in touch and then we work together, maybe if it is possible. Or we can have, I can have your contact, then we can talk more about how we can streamline this. Thank you.
Sure. You can send us an email at Atom, and I think Megan, there's ongoing activity in Uganda, so we can of course keep you informed of where we are and what is the process. Yeah. Thank you. So Megan, let me hand over to you, please. Thank you.
I just wanted to let everybody know that the World Cancer Congress is happening this year in Geneva. If you haven't registered for it and are interested, please do. We are open for registrations up until the day of the event. I think there is special pricing for UICC members. And of course, as UICC members, we really are very happy that you are with us here today for the virtual webinar. And we hope that if you have any questions or about Congress or about just what we talked about here today, and we weren't able to address your questions, please send us a message in the emails that we wrote in the chat. About the Cancer Congress, there's an opportunity to meet with a lot of the UICC members around the world and also the ATOM team and as well as the IDA Foundation. You can find us at the ATOM booth, which will be just a booth that's located at the Global Village. We'll be there for the whole period of the Congress. So there's always going to be somebody that you can talk to for the most part. And in addition, the IDA Foundation also has a session talking about some of the things that we covered today at the time and date that's specified here. So we'd really appreciate if you could come to Congress and meet us, and we'll have a great sort of networking discussion and to see how we can move things forward.
Thank you, Megan. Megan, will we be sharing the slides and the recording?
The recording will be put up. Yes, the recording will be up on the UICC website. So if there's some things that you missed or you know, there's some things that you want to get back to, that will be available online.
Okay. I still see a hand up from somebody, from Dotsie. I think that was the question you asked.
Yeah.
Right? Yeah.
There's one more. Here you go. We'll address it.
Just stop. Let me ask a question. Hello, good morning. Sorry. Hello. Can you hear me?
Yes.
Yes.
So I'm actually on the road, but I want to ask a quick one. In all this program we are talking about, though I listened to Ramatu, I'm Dozie from Nigeria. I listened to what she said and keenly all the things that have been said. I appreciate all this effort. But I want to ask the role of CSOs in all these access to chemotherapy and access to medicine, because and the role of CSOs and non-governmental organizations, especially the patient group organizations, because the cancer patients, we are the lived experience and we know what we go through with all these things. Thank you.
That's a really good way to end this webinar, actually, because as I mentioned, Atom Coalition Secretariat in country is a UICC member and a civil society representative. And I couldn't agree with you more that people living with cancer and their families are strong advocates for access to affordable medicine. So we have built that strongly into our program. So thank you for that comment. So I think we are just at 11, perfect timing, CET, of course. I would really like to thank the team for the presentation. Thank you, IDEA Foundation, for joining us today. And as we said, if you have questions, you have our email addresses, please do reach out. And thank you very much for joining us today for this interesting webinar. Goodbye and have a good day. Thank you.